Okay, we're going to suspend to try to resolve this technical glitch.
And once again, welcome to meeting number 122 of the House of Commons Standing Committee on Health. Before we begin, I'd like to ask all members and other in-person participants to consult the cards on the table for guidelines to prevent audio feedback incidents. Please take note of the following preventative measures in place to protect the health and safety of all participants, including the interpreters. Please use only a black approved earpiece. The former gray earpieces must no longer be used. Please keep your earpiece away from all microphones at all times. When you're not using your earpiece, please place it face down on the sticker placed on the table for this purpose. Thank you for your cooperation. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on April 11th, 2024, the committee is commencing its study of breast cancer screening guidelines. I'd like to welcome our panel of witnesses. Appearing as an individual, Dr. Michelle Nadler, breast medical oncologist and implementation scientist. Representing Breast Cancer Canada, Kimberly Carson, CEO. Representing the Coalition for Responsible Healthcare Guidelines, Dr. Sheila Apavu, Chair, and representing Dense Breasts Canada, Dr. Paula Gordon, Volunteer Medical Advisor, Clinical Professor at the University of British Columbia. To all of our witnesses, thank you for bearing with us. We've had some technical difficulties and votes that have caused the start to be delayed, and we have resources until 6:30 Eastern, and so that's when we will adjourn. I understand Ms. Carson has another obligation that will require her to leave at 5:30, so we're going to start off the opening statements with you, Ms. Carson, just to make sure that we get it in. So on behalf of Breast Cancer Canada, welcome to the committee. Ms. Carson, you have the floor.
Thank you so much. Thank you very much for having me and the opportunity to speak on the important topic that this is. My name is Kimberly Carson, and I'm the Chief Executive Officer of Breast Cancer Canada. Breast Cancer Canada is the only national organization that's clearly focused on funding breast cancer research, and we've been doing that since 1991. And we advocate for more funding in breast cancer research and diagnostics and precision oncology. So certainly the task force recommendation on May 30th is of great concern to us, despite calls from patient advocates like myself at Breast Cancer Canada, healthcare providers and patients across Canada to lower the age of the systemic breast cancer screening program to 40. The task force remained with the guidelines of 50 to 75. Obviously, we have a number of research projects that go against this recommendation. We believe that the screening should be lowered to a lower age because we know for sure that detecting it early saves lives. When it's detected early and it hasn't spread, it has not become metastatic, the 5-year relative survival rate is close to 99%. So making that diagnosis at an earlier age and stage, not delaying treatment, obviously increases the survival rate. And the other thing that I would like you to consider is that there are many populations where the risk is even higher at a younger age, including Black and Hispanic women. For example, triple negative is one of the more aggressive forms of breast cancer and tends to be higher rates in Black and Hispanic women, and certainly younger, at 10 to 20% of the diagnosis. And the other consideration is women with dense breasts that are obviously at more risk with a delayed diagnosis and less chance of MRI screening. So all of this leads to sort of a burden on the healthcare system and the steps that we could take to certainly reducing that burden by an earlier diagnosis. It reduces the number of systemic treatments, the complexity of the treatments, the repercussions, the overtreatment with chemotherapy, surgery, radiation. So with patients that receive stage 3 or stage 4, their therapy go over a longer period of time. They have a greater impact, greater disability, as opposed to women who would perhaps be diagnosed at a younger and earlier stage where they could go back into the workforce, remain employed at the same time and continue to care for their families and contribute to society. So certainly earlier screening at the age of 40 is going to play a very important role for those health outcomes for our patients across Canada. We also see some inequities in breast cancer screening. There's a number of provinces where the screening is at 50, which makes it inaccessible for women at a lower age. But then we see some provinces where they can self-refer into a program certainly at a younger age. And the other thing that I would add to that is that women need to be prompted and reminded they're not healthcare professionals. It's certainly up to the task force to recommend the screening age. The other thing that Breast Cancer Canada would like to see is a review in a more timely manner. There's new therapies, there's new novel treatments coming out. Right now we're talking about mammography and screening, but in the future there'll be things like blood tests and new technologies, and we certainly would like to see that timing a little quicker, at least once every 2 years, so that we would have the opportunity to take advantage of all of the new breakthroughs in technology that we've got. We've got some amazing breast cancer researchers right here in Canada, and we should really be listening to what they have to say and helping us provide that equality and equity across Canada and helping save more lives through breast cancer research. So thank you very much for your time. Thanks for taking a moment to listen to me.
Thank you, Ms. Carson. Next, Dr. Michelle Nadler, breast medical oncologist and implementation specialist. Welcome to the committee. You have the floor.
Thank you for the opportunity to present to the committee today, and thank you for taking the time to review an issue so important to women's health. I'm a breast medical oncologist in Toronto. I speak with patients and their families about breast cancer every single day, and I see how this disease and its treatments impacts on them. We are all committed to ensuring the best possible outcomes for women and for people with breast cancer. My academic focus is in knowledge translation or guideline implementation. Through this work, I became invited to participate as a knowledge expert to the task force. The 2024 draft guidelines state as follows: breast cancer screening is a personal choice. Women aged 40 to 74 should be provided information about the benefits and harms of screening to make a screening decision that aligns with their values and preferences. If someone in this age range is aware of this information and wants to be screened, they should be offered mammography screening every 2 to 3 years. This information should be accessible and shared in absolute numbers. It should include how age, family history, race and ethnicity, and breast density, if known, may impact the benefits and harms of screening. End quote. The task force invited 4 experts, a medical oncologist, radiation oncologist, radiologist, and a breast oncology surgeon. There were 2 to 3 patient partners. All provided input on the 3 main systematic review questions: inclusion criteria for each study, outcomes of importance, and protocols. Randomized trials, observational, and quasi-experimental studies were included. The task force investigated, among others, the following outcomes: breast cancer mortality, stage distribution, and treatment morbidity. We often hear about the benefits of early detection. We are told that if we can find cancer earlier, there is less chance of death from breast cancer or less intensive therapies. It might be surprising, but early detection is not always necessarily an assurance of either of these. More and more we know that biology of disease, or how aggressive the cancer is, factors into prognosis. Outcomes of harms, including additional testing showing no cancer and overdiagnosis, were also looked at. Overdiagnosis means the biopsy-proven detection of a precancer or cancer that would otherwise never have caused the individual any symptoms or problems in their lifetime. This occurs for older women and is also well documented in younger women. All studies that met inclusion criteria and additional studies submitted to the portal were reviewed by the evidence synthesis team. The team included 2 radiology experts and a GP oncologist. All studies were rated for certainty, i.e. how likely they are to represent the truth, through something called the grade methodology. Once the data analysis was completed, the evidence was displayed to our working group and we reviewed and discussed the data. In key question 3, the task force undertook a systematic review related to the values and preferences for women ages 40 to 74 for screening. This showed that the majority of women 40 to 49 felt that the harms outweigh the benefits for screening. However, members of the task force working group agreed that there is large variability in women's values. The task force met separately to look at the evidence in totality, looking at all included study results and comparing them. One of the criticisms of the task force is that certain studies were not considered. It is normal in the scientific method of a systematic review to question why some results are outliers compared to others. This does not mean that they are dismissed. The task force cannot base its recommendation on only 1 or 2 studies. They must look at the evidence in totality. Everything above that I have stated are the facts as I know them. To be clear, what follows is my personal opinion. I think it is commendable to have guidelines state specifically that personal risk factors, benefits, and harms should be clearly communicated to women to inform a decision, and that the decision they make should be respected. The alternative, suggested by many critical of the task force, is to systematically screen all women starting at 40. I have concerns that this is not respectful to the range of values that different women hold about the benefits and harms in screening. Some women will want to screen and others won't. Both sets of values should be respected. I went into this process with an open mind of what the data would demonstrate. I truly believe that the task force went into this open-minded as well. The science shows us that there are both benefits and harms to breast screening. In individuals not at high risk, there is equipoise and substantial uncertainty. There is more uncertainty than the public may think. Sometimes science gives us an answer we didn't expect or we don't want, but we should still listen to it. In medical practice, when there is close equipoise or uncertainty, the best thing to do is have a shared discussion with each individual patient in front of us and to respect their decision. Thank you.
Thank you, Dr. Nadler. Next, representing the Coalition for Responsible Healthcare Guidelines, Dr. Sheila Apovo. Thank you for being with us. You have the floor.
Thank you for having me. Honorable members of the Health Committee, thank you to this committee for convening this important study with such urgency. I'm Dr. Sheila Apovo, a general radiologist with an interest in breast imaging. I chair the Canadian Society of Breast Imaging Patient Engagement Working Group, and I also founded and chair the Coalition for Responsible Healthcare Guidelines. I speak today about my serious concerns about the recent draft guideline issued by the Canadian Task Force on Preventive Healthcare regarding breast cancer screening, recommending against screening women 40 to 49. This guideline stands in stark contrast to those provided by the U.S. Task Force, the Canadian Cancer Society, and the majority of Canadian provinces, all of which have recognized the need to lower the screening age to 40. The Nurse Practitioners Association of Canada has also recently withdrawn their endorsement of the similar 2018 Task Force guideline. The Task Force decision not to routinely screen women 40 to 49 is biased. This stance was seemingly predetermined. The Task Force leadership indicated in the media in early May 2023 that there was no need to change the Canadian guidelines. This was before the evidence review began. And lo and behold, this prophecy was fulfilled almost exactly a year later. How does the task force come to such different conclusions than the rest of the modern world? Without the context provided by the fulsome guidance of experienced content experts, they amplify harms, such as overdiagnosis and callbacks for additional imaging, and they minimize the benefits of early detection. One rarely hears the task force discussions mentioning the lives saved or mastectomies prevented by screening. The U.S. Task Force has acknowledged and acted on the increasing incidence of breast cancer as well as racial disparities. Canadian research has found similar trends here at home, and the Canadian Task Force even acknowledges higher mortality in Black women in their 40s, but fails them in its guideline, begging off on a lack of evidence, abandoning common sense and the precautionary principle. In every racial group except white women, breast cancer starts to peak in the 40s, and yet the task force makes little attempt to accommodate these groups. While acknowledging the influence of race, ethnicity, family history, and breast density, the task force has minimized these important individualizing issues. One of the misconceptions of the task force is that improved life expectancy is attributable to better treatment, with an implication that treatment is a substitute for early detection. This is problematic. Women with early stage diagnosis are far more likely to live out their full lifespan with less of the aggressive treatment, existential dread, and generational trauma of a woman and her family dealing with a late stage cancer diagnosis. Simply put, women with smaller, less advanced tumors tend to live longer and better quality lives, and screened women tend to have smaller tumors than non-screened women. It has been mentioned by the task force member, or by some task force members, that screening should be limited to control costs. This is a false economy. Screening is an investment, considering the cost of modern treatment. Work done by researchers in Ottawa have demonstrated that by screening annually from age 40 to 74, Canada would save around $460 million annually. The costs of treatment far outweigh the cost of screening. We cannot afford not to screen. If instituted, the consequences of these new task force guidelines will be dire. Many young women will potentially pay with their lives. Most provinces and territories have recognized this and have allowed self-referral for women aged 40 to 49. However, the recommendation of a primary care provider is still the strongest predictor of whether a woman will actually go for screening. As long as doctors are being given the task force message that women in their 40s don't need screening, many of those women won't get access. By continuing to make the same recommendation that the task force has made since 2011, Canada's national guideline is falling farther and farther behind the provinces, other countries, and expert recommendations. This has led to patchwork access for women across the provinces. And unfortunately, these guideline problems are not isolated to breast screening and are a pattern seen in multiple other guidelines during the past 15 years of the task force's existence. We must not allow these guidelines to stand as they are. We must have a guideline that is informed by the latest evidence, one that truly serves the best interests of Canadians, and with respect, looking at its record, we must dismantle and rebuild this task force. Thank you very much for your attention to this issue.
Thank you, Dr. Apovo. And finally, representing Dense Breast Canada, Dr. Paula Gordon. Welcome back, Dr. Gordon. You know the drill. You have the floor.
Thank you. Honorable Health Committee members, the Canadian Task Force understates the benefits of screening, but they are obsessed with what they call the harms. They recommend against screening women in the 40s, even though women aged 40 to 49 are 44% less likely to die of breast cancer if they have mammograms. And they recommend against supplemental screening for women with dense breasts, even though many more invasive cancers would be found earlier if it was used. I'll explain what they think the harms are. Even that term is misleading. There really are risks or limitations. The first is the anxiety women experience if they are recalled for additional tests after a screening mammogram and are not found to have cancer. Now, only about 5% of recalled women are diagnosed with cancer. That anxiety is real, but it's transient, and it pales in comparison to the anxiety a woman feels if she learns that she has an advanced cancer and that she faces the possibility of death or at least months of surgery, radiation, and chemotherapy, which might have been avoided had her cancer been found earlier. The task force gives false equivalence of this anxiety to delayed diagnosis and advanced cancer. The task force also disproportionately focuses on overdiagnosis. You just heard that's the theoretical possibility where a woman is diagnosed with cancer, is treated for it, but dies of another cause sooner than her breast cancer would have killed her. For example, she may die of a heart attack sooner. Overdiagnosis is much less common in younger women. They're less likely to die of other causes, and their cancers are more aggressive than in older women, so they grow and spread faster if untreated. In women in the 40s who get breast cancer accounts for 91% of their deaths, but in women in the 70s, it accounts for only 48%. Cancer does not regress if it's left untreated. They may grow fast or slow, but if given time, they will spread and kill. Doctors Wilkinson and Seeley, working with Stats Canada, showed that after screening of women in the 40s was stopped in response to the task force recommendations in 2011, the rate of metastatic cancer went up by 10% for women in both the 40s and 50s. Overdiagnosis is only important if it leads to overtreatment. With current testing and rapidly advancing research on predicting how a given cancer will behave, oncologists can offer less aggressive treatment for some cancers. But if women choose not to be screened because of the task force's emphasis on overdiagnosis, they lose the opportunity to find their cancers early and save lives. In their 2018 review, the task force said that the rate of overdiagnosis was 48%, based mainly on an old, flawed Canadian study that has been discredited. For the current review, overdiagnosis was 11% when that discredited study was included, but only 6% when it was excluded. That 48% rate included into the decision tool created by the task force and used in shared decision making may well have been responsible for countless deaths. Screening is not perfect. Women should be told about the risks of being recalled and overdiagnosis, but they should not be discouraged from screening. Some members of the task force say that screening is less important because treatment's getting better, but it's not a contest. Screening and treatment are synergistic. Cancer can be treated more effectively and less aggressively when it's found earlier. Of course, there are anecdotal studies of women with early cancer who didn't do well and women with stage 3 who did, but it's like hearing stories about people who smoked all their lives and died at age 95 without developing lung cancer. Reliable data trumps outlier stories. Some members of the task force claim that screening can't save the lives of women with rapidly growing cancers. That's not true. Stats Canada has shown that when triple-negative cancer is detected at stage 1, the 5-year survival is 96%, but at stage 4, it's only 7%. The stage of diagnosis does matter. And it's more than about just saving lives. Chemotherapy can often be avoided when cancer is found early. Most patients with stage 1 cancer don't need chemo. Most patients with stage 2 and higher do need it. The stage of diagnosis does matter. Early detection also allows for less aggressive surgery, lumpectomy instead of mastectomy, sentinel node biopsy versus axillary dissection. The traditional armpit surgery to sample lymph nodes leads to permanent swelling of the hand and arm in about a third of women. The stage of diagnosis does matter. So to sum up, the science is clear. Screening finds cancer at a lower stage, improves the quality of life for women with cancer, and saves more lives. The alleged harms are not reason enough to deny or discourage women from the opportunity for early detection. And if screening is not offered starting at age 40, it will be inaccessible for many women. So no one's going to force a woman to have screening, but she needs to have the choice to attend. Thank you very much.
Thank you, Dr. Gordon. That concludes our opening statements. We're now going to begin with rounds of questions, starting with Ms. Goodridge, please, for 6 minutes.
Thank you, Mr. Chair, and I want to thank all the witnesses for being here today and providing your testimony. I think this is such an important study, and it's wonderful that we were able to get to it so quickly, especially in light of the updated guidelines coming out, and the guidelines that I don't believe hit the mark by any stretch of any imagination. Dr. Gordon, as an expert in the field, do you believe that women have the capacity and the capability of deciding for themselves whether or not to get breast cancer screening?
You're on mute, Dr. Gordon.
Thank you. Sorry. Yes, I believe women are capable, and it's patronizing the task force to make a decision for women. If given the correct information, which is not currently in the decision tool, and given it in multiple different ways, women can make the decision for themselves. The task force plays down the benefits by using absolute numbers. They say how many women in 1,000 will benefit, for example, and they make it sound like there's not a big difference between 1 in 1,000 or 2 in 1,000. But if you multiply that by the number of women in that age group in the country, you'll find that there could be 400 to 600 fewer deaths every year in Canada if women in their 40s are allowed to attend. I think women know what that means.
Thank you. I appreciate that. And my mom was diagnosed with breast cancer when she was 48 years old, and she passed away from breast cancer at 49 years old, leaving behind 4 kids. I was the oldest, and that put a huge strain on all of us. And the fact that if I was to have the same symptoms right now, I would have to argue with a doctor to try and get screening, to me seems absolutely insane. What are the benefits of early diagnosis to Dr. Gordon?
So with early diagnosis, women can have better treatment that's effective. They can have a lumpectomy, for example, instead of lose a breast with a mastectomy. The way they do the lymph node staging is also less aggressive. It's called a sentinel node biopsy. And compared to the traditional method, which left about a third of women with permanent swelling in their hand and arm, the less aggressive sentinel node biopsy, likelihood of lymphedema is as low as 2%. They can function much better if they can avoid chemotherapy, which is possible depending on the biology of the tumor and the stage of the tumor. So having chemotherapy for some women is the worst part of breast cancer, and to be able to avoid it is a huge benefit. And then they can go to work while they're being treated and continue to care for their children, and in some cases look after aging parents. They're contributing to the economy.
Thank you. So I'm now going to ask a really broad question to all of the panelists, and perhaps starting with Dr. Apavu. If you could write screening guidelines today, what would your screening guidelines be?
Notes on that.
Wonderful.
I've got an opinion about everything. So,
The mic so that we can
certainly.
hear you properly.
Sorry. So what we want is, to start at 25 to 30, asking the questions of the patient, the woman. So asking a few questions about family history, knowing if that person needs to be on a high-risk channel to start with early on in the game, so that we're not finding out by accident that, that person really should have been. What is horrible to see is when we see women who get cancer and they're discovered late, even with a late stage diagnosis, even in their 30s, sometimes even before they're eligible for screening. But once you talk to them and you realize they had a really strong family history and they should have been getting screening all the way along. And of course, I can't find my notes on this. But we would like to see annual screening from 40 until about 10 years, when the person has, under 10 years of life expectancy. So, and that is shown with modeling and with evidence to save the most lives and to have the fewest treatment harms. So, what we also would like to see is anybody who has dense breast tissue should be offered supplemental screening with either ultrasound or MRI, most commonly ultrasound, but for very dense breast tissue. And in Europe, they're starting to do this. Very dense breast tissue, patients should get MRI screening. That's about my...
Wonderful.
Dr. Gordon might have something extra to add.
Because I
there.
do see that Kimberly Carson does have to leave. Kimberly, could you perhaps provide us with your recommendations?
Thank you so much, Leila. Obviously, Breast Cancer Canada would like to see the age lowered to the age of 40 for all of the reasons that both the doctors had recommended. And I think at the age of 40, although women can make up their mind, it is that prompt, it is what we hear from the patients every day, that they say, oh, I got the letter in the mail, or my doctor said I now qualify, and they go and get that mammogram done. And it catches something at a very early stage. And because we speak to those patient advocates on a daily basis, we hear that frequently. So by providing them with the opportunity to be screened at the age of 40, and certainly profiled if they should even be screened at a younger age because of family history, that we would definitely be advocating for that and asking the task force to please lower that age to 40. And certainly when we have more technology available in the future as well, we would have a better opportunity to offer more technology and more treatment options for women at a younger age.
Thank you, Ms. Carson. Thank you, Ms. Goodrich. Next, Ms. Kayabaga for 6 minutes, please.
Thank you, Chair. I also would like to extend many thanks to our witnesses. Perhaps I can also start with Ms. Carson, because I know that she has to leave us soon. In your opening remarks, you did talk about Black and Hispanic women and the disparities that there is in breast cancer and early screening for them. Do you think that there's sufficient data available to be able to make any suggestions on practices for both Black and Hispanic and Indigenous women?
I mean, I think there's a lot of research data. There is perhaps some shortage of some data in Canada due to the fact that we haven't always tracked ethnicity, but we do now. There's certainly to the south of us a number of research studies, and I would encourage the task force to take a look at those. And I think what we need to do is pay more attention moving forward as well. We certainly see the risks in Black and Hispanic women at a younger age with certain types of breast cancer, as I mentioned, the triple negative. So I would like to see, as we were talking earlier about, the opportunity for women to have that profile done with their family doctor, their primary caregiver, that if they are at higher risk, is there a family history? Are they at a higher risk because of the ethnicity as well? Those all should be added in together, and perhaps they should be looked at the age of 30 even.
Last year, in February of 2023, there was a report that came out, and I think CBC reported on the study that found that members of the Black communities were less likely to get screened for cancer, and as a result, they have increasing mortality rates. What are the best practices for making decisions about screening in situations where we know that there's a community that is likely have a higher rate of death because there's less access to screening? And perhaps if Carson, you could just quickly answer, and then Dr. Gordon can also answer that question. Thank you.
Certainly. I don't think that they have less options for or access to screening. I think we need to do everything to encourage every woman that has access to be screened. And I believe that there should be an opportunity for women of Black and Hispanic descent to have more in-depth review of their family history and the opportunity to be encouraged to screen. And again, I go back to, if we have the screening and detection lower to the age of 40, would that catch more cases? Would they have that availability to say, oh, this is something I'm supposed to get done at the age of 40, as opposed to waiting to the age of 50?
This is actually through a study that was released last year. So it is proven that they have less access to screening. I'll go to Dr. Gordon to see what she has to say. She looks like she has a lot to say on this.
Please, thank you. Well, the first point I want to make is, you've heard a couple of times, family history. It's very important that everyone understand that. I sit down for this one. 85% of women who get breast cancer have no family history. Women are at increased risk if they do, but that's not the only risk factor. And the other omission has been it's Black, Asian, Hispanic women especially are at risk of developing cancer younger, but there are other groups who are at high risk, like Ashkenazi Jewish women. The reason that mortality is so terrible in Black women is they're at a much higher risk to get these rapidly moving triple negative cancers, and Black women are 40% more likely to die if they do get breast cancer for that reason. And those are the aggressive, fast-moving cancers, and the way to find them as early as possible is not only to do the mammogram every year, but if a woman has dense breasts, and that's more common in Black women, they should also get supplemental screening. And whether it's with ultrasound or MRI should depend on their actual risk level, which can be determined with online risk calculation tools that are easily accessible with just a few questions. So a Black woman with dense breasts and a family history is probably going to be at a high enough risk to justify not only screening her younger, but screening her more often and with better technology like MRI.
I see that I can't see her name because it's too far, but the person, Dr. Narda, wanted to also add some comments.
Sure, thank you. So just to clarify, the overall incidence of breast cancer in the Black community is less than average, but it does occur younger and the prognosis is poor, as you said. I also want to reach out to Layla and say that I'm absolutely so sorry that this happened to you. What we don't know is whether screening would have changed that outcome or not. We simply don't know. Screening helps some people, but it doesn't help everybody. A second point
Thank you.
is that
I'm just
Thank
gonna
you.
just because I have a short amount of time, so I just want to get through some of my questions. In December of 2023, Dr. Anna Wilkinson told the committee that non-white women, including Black, Indigenous, Chinese, South Asian, and Filipino women, have a peak of breast cancer diagnosis in their 40s, while white women have a peak age in their 60s. How and why are racialized women differently affected by breast cancer?
Who's that for?
I'll go to Dr. Gordon.
Dr. Gordon?
Well-
I'm sorry she didn't leave much time for a response. As
Oh.
concise as you can possibly be, please.
They're at risk because their cancers aren't found earlier, because they're not screened starting at age 40, and they deserve the same opportunity of early detection as Caucasian women. So racialized women, everybody should be screened at age 40, but absolutely racialized women deserve their cancers to be found as early as Caucasian women's.
Thank you, Dr. Gordon. Pour 6 minutes, s'il vous plaît.
Merci beaucoup, Monsieur le Président.
Thank you, Chair. Dr. Gordon, we've heard that overdiagnosis can trigger overtreatment and have other negative effects, complications. So there's a need to establish the accuracy of these diagnoses. A lot of prejudices. Do you think that this is an obstacle to systematic screening of women between starting at age 40 and 50?
Overdiagnosis is only important if it leads to overtreatment, but overdiagnosis actually applies to real cancers. These are not false positive. These are cancers that have been diagnosed on a biopsy. But from that point, the patient is referred for care to a surgeon, to an oncologist, to a radiation therapist, and then her treatment has to be tailored to her. If that woman has advanced heart disease and her life expectancy is short, she will not be treated with the same aggressiveness as a young woman who's in very good health. So we have to screen to find the cancers, and then once we find them, the treatment is decided based on the individual patient, not only the characteristics of the cancer, but the patient's general health and how much treatment she can tolerate and how likely it is that that treatment is going to help her in the long run. But to say that we shouldn't screen because of overdiagnosis means we'll never find those cancers, even the ones that could be treated, even the more lethal ones, and especially the ones in younger women, because as I explained, they're less likely to have heart disease and be at risk of dying of a heart attack. So if we do find their cancers, they tend to grow faster, they need to be treated, and that's not overtreatment.
Êtes-vous d'avis qu'on a surdiagnostiqué le surdiagnostic dans les études?
Do you think that overdiagnosis has been sort of exaggerated in these studies? Dr. Gordon?
There is confusion between overdiagnosis and what a false positive would be. So the term false positive is incorrectly used by the task force. It's pejorative to refer to something abnormal on a mammogram that needs additional tests. 95% of those turn out to be negative, and the patient is reassured that everything's fine. And there's a big difference between that, which is not a cancer, and overdiagnosis, which is. But overdiagnosis, as I said, is not a reason to deny screening to younger women. It's not even a reason to deny screening to older women unless they're very sick. As long as a woman is healthy with a life expectancy of 10 years, then it's reasonable to offer her screening, because if we can find a small cancer, sometimes they can be treated very easily, sometimes even just with a hormonal medication, or sometimes just a small operation and not do all the other stuff like radiation and chemotherapy. So that's when it's in the hands of the doctors who are treating her to use their skill to decide how much treatment to offer her.
Le groupe de travail américain
The American Task Force on Preventative Measures recommends that we can screen as of age 40 to save lives. And they even indicate that we might be able to